All right, DIC. So you don't need to write all this. It's very simple. Nope, you don't have to write it. Okay, DIC, disseminate, means to what? Spread. What does intravascular mean? Inside, right? Inside the veins or arteries. What does coag mean? Clots. So, DIC is the spreading of clots in the veins and arteries. Pretty simple, right? So if all you want to write for DIC, spread of clots in veins and arteries. Mic drop, boom, done. Okay? So what isn't it? It's not a disease. Just like everything else we've talked about, it is a condition in response to something else. So an abnormal response of the clotting cascade, secondary to some kind of disease. So we cut ourselves, our clotting cascade goes into effect because we want that clot to, or that cut to stop bleeding. We clot and that's it. Now you have something like, because there can be acute, subacute, or chronic causes. So you have something like, for an acute cause, the patient becomes septic, and that initiates the clotting cascade to go into overdrive. The patient is pregnant, so it could be acute or subacute. Their malignancy, that goes all across the board, acute, subacute, or chronic. Something initiates the clotting cascade to go into overdrive. Normally, it only goes, it's activated when, like we say, we have a cut. There's a reason we need to clot our blood. Now, the clotting cascade goes crazy, and it's just clotting all over because DIC is the spread of clots into all those veins and arteries. So again, we don't need to spend a lot of time on this. Just know that you can't treat DIC. You only kind of treat symptomatically with DIC. You have to treat the underlying cause in order for DIC to stop. Systemic lupus erythema. So, less important to know all these details, more important to understand that it is a response to some other disease process. And if you want DIC to resolve, you have to resolve the underlying process. So patho. Okay. There's the trigger event. The patient is septic, your OB patient. There's a malignancy. Something triggers. And your normal coag mechanism goes into overdrive. So normally IV thrombin is produced, but now it's produced a lot. And normally fibrogen turns into fibrin and enhances the platelet aggregation. But again, this process is in overdrive. So instead of just having clots where we need them, at a cut, at a source of bleeding, we now have clots deposited, that remember, DIC, widespread, deposited into all of our capillaries and arteries. So it's getting into the capillaries and arteries of the hand, into the liver, into the lungs, into the legs, everywhere. So you've got clots everywhere. And it's going crazy. It's in total overdrive right now. So normally this process would happen at just enough to fix the problem. But now it's going just crazy, and it's just producing clots. And because it's depositing in all these capillaries and arteries, and we've got thrombosis everywhere, our organs start to fail because everything beyond the point of the clot is not getting any blood, right? So if you have clots in the lungs aren't getting the blood flow. If you have clots in the liver's not getting blood flow. If you have clots in, the hand, you don't have blood flow to the hand. So you have to worry about ischemia and all your organs failing. So that's the first thing that's happening. Your body gets triggered and goes into like clot making mania mode, okay? At the same time, on the other end, normally when there's a clot, the body sends these fibrin lytic. So what does lytic mean? To break up. So I already told you that fibrinogen turns to fibrin. So normally when there's a clot, your body will send fibrolytic agents to break up those clots, right? So you can write, if you don't want to write all this, you can write FSPs, fibrin split products, FSPs, or fibrin degradation products. So they are anticoagulant, they inhibit. All right, so your body is like clot, 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 clot. And then it's like, okay, break up the clot, break up the clot, break up the clot. So, but it's going so fast that you use up all your clotting factors. So blood loses the ability to clot, and then you bleed. So that's why you have clots going on and bleeding going on at the same time.
So it's like a mix between you used up all your clotting factors, and so now you
don't have any left. But you already have the clots out there.
But while they're out there at the same time, you're already resolving them at the same time, even though now you're not making any more clots with the fibrin split.
Hold on. Back up a little bit. Your first thing your body does is go into overdrive and make clots.
Yeah.
And there are clots everywhere. Mm-hmm. So your body's response to that is to go break up those clots. But your body...
That's what it's written up on top. Ish.
It's at this... Yes. So in response to that, it's going to try to break up all these clots. Right. But your body, let's say it makes 100 clots. And again, arbitrary numbers, but just to give you an idea. Let's say your body makes 100 clots, but you only have enough anti-clot for 80. So you still have those 20 clots out there. And now you've used them all up, and your blood can't clot at all because it's put all of its effort into breaking up clots instead of keeping the blood from clotting.
The end of the story is bleed out.
You bleed out. But you still have to worry about organ failure because you still have those clots out there. And they're not being broken up because you have no more fibrolytic agents to break them up. You've used them all up. You have more clotting factors than you do break up factors. And then they get all used up. And then you're just bleeding.
And then you can't clot, like with OB, you wouldn't clot anymore.
Exactly. Now you can't clot anymore. So, and the clots that are out there are there. And you can't break them up. And now you can't clot anymore. And so you're just bleeding out.
Did you need the first 100 clots to begin with?
No, because remember, it's overdrive. This is a trigger. This is an abnormal response. So you didn't need them to begin with. They were just abnormally made because something triggered this whole process.
So they're just pumping along your arteries and they see a cell.
No, it's like sepsis. You get septic and it triggers the clotting cascade. And then your clotting cascade goes, I'm going to make all these clots
That you don't need.
That you don't need, and they get deposited in everywhere, every organ, every, artery, capillary. And then you end up with clots everywhere, organs failing because anything distal to that clot is not getting blood, it's becoming ischemic. So clots are deposited, so you have clots that you need to break up because you need blood going to those organs. But at the same time, you have to be careful because you don't have any clotting factor, so even just normal, clotting factor is affected. So now I'm bleeding out everywhere. So you've got two different things going on. That's why you can clot and bleed. And that's why it's important to understand this because that's how we treat it. So, does anybody need any more time with this? Everyone's good? All right. So you're going to have bleeding manifestations and you're going to have thrombolytic manifestations. So you're going to have things like if you try to put an IV in, venipuncture hemorrhage. If you try to put an IV, they're going to bleed out, right? They're going to have bruising and petechiae everywhere. Ecchymosis, petechiae. They're going to have nosebleeds and gums. So your patient with DIC, they're not going to, if let's say they're vented, you have to be careful. Mouth care, we just talked about how important mouth care was, right? But yet you're not going to be brushing their teeth because if you brush their gums, they're going to bleed out on you because they can't stop and make that clot. So you have to make sure you use things like swabs for the mouth. GI bleed. So you're going to measure, look at their stools. Make sure that you don't see anything. They're at risk for intracranial bleed. So monitor any CNS changes. Blood in the urine or bloody sputum. So, pretty much anything that could cause a bleed, they're at risk for, right? Because they're not clotting anymore because they've used up all their clotting factors. But they used up all their clotting factors on those clots that are already out there. So they're at risk for ischemia, gangrene, a paralytic ileus. So you have to be very careful about feeding these patients, listening to bowel sounds. They can develop ARDS, oliguria if they have decreased cardiac output to their renal system, and even coma. Because if their brain is not getting blood. So you have to be careful because we have all these signs and symptoms of bleeding, but yet they're at risk for ischemia because of the clots that are already out there.
What's the last one? Is it
Coma. Yes, ma'am. All right. So this is what the picture that's in your book. And it just says that, you have the events leading to the thrombosis and then the events leading to the bleeding.
So you never run out of the thrombolytic.
Yes, that's why the clots are still kind of there because you do run out of them because they can't break up the clots anymore. So my diagnostic studies are going to be basically based on my patho. So FSPs are those fibrin split products, or FDPs, but most people know them as FSPs. Like a D-dimer. Have you guys seen a D-dimer on a blood lab, or when you're looking at your results and didn't know what that meant and you wrote it down in your care plan because it sounded good? All right. So they're not normally present because we don't normally see them in high enough numbers breaking up clots. But because we have so many clots we're trying to break up, you're going to have high FSPs or a positive D-dimer, okay? Because we're going to see them there. We don't normally see that number so high because, they break up some clots, but they break them up and then go back to normal and it's okay. So when you have a high FSP, that means that they're out there trying to break up the clots and we've used them all up. Your platelets are going to be low. Your fibrinogen is going to be low because we've used it all up. And PT and PTT show us what? Clot times, right? So if we're not clotting, the time is longer. So you should expect your PT and PTT to be high. So it's easy to figure out the diagnostic studies when you understand the patho that's behind it. You don't have to worry about that. All right, I'm not going to go over the nursing diagnosis, but there's some if you need them for your care plan. So how do we take care of these patients? Again, because we need to stabilize them, oxygen, volume replacement, and treat the cause. We're not going to be able to treat DIC unless we treat the cause. They need platelets and chirociprate. That's the FFP. That's a clotting factor. So it gets a little confusing because they're bleeding out. And you're like, well, part of the problem is they have clots. Well, yes, they have clots that are there and like, you know, already deposited. But now I'm bleeding out. So I need to give them clotting factor so that they stop bleeding out. They're losing a lot of volume. So I need to give them platelets, FFP, packed red blood cells. That's part of the volume that I'm going to give for. And then this is where students are like, whoa, wait a minute. They're bleeding out. Why are you giving them heparin? Because they have those clots that are deposited, we have to break up those clots. Because remember, the FFP, the chirociprate, the packed red blood cells, packed red blood cells platelets are filling volume, the volume that we're losing from bleeding. The chirociprate, the FFP, are helping clot so I don't lose any more volume. But I've already got all these clots deposited that are causing ischemia and organ failure, and if I don't get rid of the clots, then I'm going to continue to have organ failure. So I need to use something like a low molecular weight heparin in order to break up some of those clots. So it gets a little confusing, but you do need both. Are we good? So, how do we know we've done a good job? The patient's alive. That's always good, right? And we maintain tissue perfusion. Because if we don't, then these patients go into shock, which is what we're going to talk about on Monday. So we know that the brain is being perfused if the patient's alert and oriented. We know the heart is being perfused if they don't have any chest pain, if they have good cardiac output. We know the lungs are being perfused if they're nice and clear and a good respiratory effort. We know the kidneys are being perfused if they have good urine output. So our goal is to make sure that we keep our volume up, keep the organs well perfused by having good volume and breaking up clots that are preventing volume to getting to them. And that is DIC. I told you it'd be quick.
What's the prognosis with this?
I don't know an exact number. They're not great. If they go into DIC, they're typically super sick. But as far as an exact number, I don't know that.
Even if they fix them by then, you got something wrong.
Yeah, they're still sick. I mean, they're still sick. Yes, there's going to be some leftovers, but as far as an exact number, I don't know. Yes. Yeah.